David's ready.
Good. All right, good evening. Hope everyone is doing well. I'll turn the meeting over to our interim city manager, Mr. Mike Murphy.
Thank you, Mayor Walker. My comments will be brief. We come to tonight's meeting after council had some discussion, after public comment about diversity and cultural competence in behavioral health resources. And we've kind of expanded that discussion for you all with this work session this evening. Kaki Dimmick has worked with a lot of community partners to create the agenda you have in front of you. The city, for a period of time, was the host of the Community Mental Health and Wellness Coalition, now hosted at Region 10, and they, among many other partners, will be speaking with you tonight. We will certainly address the issue that you had, particularly about psychiatry this evening, but I hope that similar to your discussion about Second Chance City, that you'll see there's a real diversity of resources in this community that lead to the strength in the behavioral health realm, and certainly I hope that you'll also hear about some ways that you can contribute to bringing more resources to the table. So I'll turn it over to Ms. Dimmick.
Good evening. I just want to say a few words about the fact that this is entitled the Behavioral Health System of Care work session, and in the next 2 hours there's no way that we could possibly touch on the entire system of care, even if we were exceptionally brief and concise in talking about who we were and what we did. The entire behavioral health system of care starts with community-based primary prevention. It goes all the way to deeper end long-term residential treatment institutions and facilities. And again, there's no chance that we could touch on all of those things in 2 hours. And so this is a work session that's focused on local community-based services, with a strong emphasis on organizational equity issues in the behavioral health system of care, and with an emphasis on peer supports. I'm going to ask that the folks who are on the agenda, that we treat this as informally as we possibly can. It's an artificial context, but that we try to remember that we're one community, and that we stand up and talk when we want to, and so there's a mic in the middle there. So when you're moved to make a comment, please just approach the mic. On the agenda, you can see that there are a number of folks who are identified as people who, if you don't have an agenda, there's some in the back, and hopefully someone on your row will have one. But if you're next, just stand up and join the mic. If you want to talk before the next person wants to talk, stand up and join the mic. We hope that this will be conversational, and that there'll be an opportunity for questions both directions. So to get us started, we have Elizabeth Irvin, who is co-chair of the Mental Health and Wellness Coalition.
I would like to make this conversational, but I actually did prepare my remarks. So it will feel formal, but I appreciate the invitation for it to be a two-way conversation and dialogue. So first, I want to thank City Council for recognizing the importance of behavioral health in our community and inviting us to participate in this conversation. My name is Elizabeth Irvin. I'm the Executive Director of the Women's Initiative. I also serve as the co-chair for the Community Mental Health and Wellness Coalition. And I'm here for 5 minutes or less to talk to you about the Community Mental Health and Wellness Coalition. That's my task right now. So that's what I'm going to do around what are those efforts that we're doing in the community right now. So the coalition's mission is collaborating to promote behavioral health and wellness through planning, advocacy, and access. It's a multidisciplinary group composed of over 20 organizations and community members. And we have 3 priority areas with our community that align with our community health needs assessment. The first is increased access to and utilization of mental health and substance use disorder services. And we have a service system committee that meets monthly to identify gaps and barriers and provide networking and for our safety net of care. We also have specifically been looking at medication-assisted treatment, promoting Medicaid expansion, and integrated care. Our second priority area, again aligned with MAP and the Community Health Needs Assessment, is strengthening the behavioral health workforce to address cultural, linguistic, and peer support, which is the language of the Community Health Needs Assessment, but which is really about health equity. And there's a few different areas the coalition has been working in this area. First, I want to highlight Rebecca Kendall's efforts to be researching national best practices and bringing that to our community to help the conversation grow in a way that promotes this being as effective as possible. We've had some trainings and community discussions, including with Darnell Walker and on health literacy. The coalition received funds from the Heal Charlottesville Fund to expand Region 10's community-based recovery support services in Friendship Court, and for the racial and awareness and sensitivity training that Dr. Kenneth Hardy is planning to do and Jean Cash will be addressing later. In addition, I'll just say the goal overall for the coalition is that all the member organizations will be committing to doing organizational assessments on diversity, equity, and inclusion, and also to address the recommendations that come from those assessments. And the third priority area is implement policy, system, and environmental changes to improve mental health and substance use outcomes. And there's 3 areas under that. I think I'm doing okay. I'm trying to speak fast. One is on the opioid epidemic and really trying to come together and convene more than 50 participants, both from UVA, Centera, the Health District, and others, to look at how we're going to collectively look at prevention and treatment of opioids. And that includes things like Medicaid-assisted treatment, new drug disposal boxes, work groups on prescriber education, and more. Relative to disaster mental health, following August 12th, the coalition reached out to national experts so that over 100 people were able to attend free training on psychological first aid and skills for psychological recovery. And those folks were then woven into the Medical Reserve Corps, which is part of the health district's effort to do disaster preparedness and really bringing behavioral health into the scope and practice when any kind of disaster comes. So for the anniversary, there was a lot of effort around having a behavioral health response on the ground. And relative to stigma reduction, which is a component of systems improvement so that people feel like it's okay to reach out for help, that it's really not about what's wrong with you, but what happened to you and the trauma-informed care approach. I want to specifically talk about the Help Happens Here campaign, which was a website, phone line, ad campaign in collaboration with the Partner for Mental Health, which supports both stigma reduction and access to care, as well as specific efforts within our Public Relations Committee and with Brian and others at the city related to providing trauma-informed resilience-building messages related to August 12th anniversary. So if you see this flyer, it was everywhere on the downtown mall in the weekend of the anniversary. And finally, I just want to bring everybody's attention to the banners that are around the room. On Friday, this past week, for First Fridays, we had the event for the banners for resilience and recovery. And I wish I knew the actual number of how many banners were here, but Molly, hundreds of banners. Myra was able to come and do 3 of her wonderful poems. There was also the players from On Our Own that did a presentation. And again, it's really about saying this is what hope looks like. This is what it means to come together as community and try and build resilience and care. Why is this all important? To improve health equity, to implement best practices like trauma-informed care, and so we can support each other to keep learning and improving as a community. The coalition is open to anyone and really want this to be the beginning of a conversation. So I look forward to hearing the rest of tonight. Thank you.
Hi, I'm Dr. Judith Curiel. I'm a clinical psychologist, and I work as a therapist at the Women's Initiative. And first, I want to thank you all for giving us a chance to speak about what we do. And the thing I'm going to talk to you about is an agency that we formed about 2 years ago, somewhere around there. It's called Central Virginia Clinicians of Color Network, CVCCN. We try to empower communities of color through clinical excellence. We are made up of around 50 mental health providers from bachelor's level up to the PhD level. We work in the private and public sectors. We honor our collective experiences as people of color, but we acknowledge and respect our intersectional identities and their impact on our work. People of color are those who identify as non-white and share some common experiences related to systemic oppression and marginalization in society. The mission of our group is to provide support and professional development to clinicians of color to elevate the standards of care and therapeutic services for diverse populations. Our vision is a supportive network that empowers clinicians of color and builds capacity for providing culturally responsive mental health treatment. Our values are that we believe clinicians have the right for their work to reflect their whole selves. We believe clients have the right to access quality care that respects their cultural experiences. Some of the things that members of our group have done are, first of all, 19 members have completed part 1 of a training that's, it's EMDR, which means eye movement desensitization and reprocessing. That's a training that's specifically designed to help us work with people through their traumas. They're getting practice hours and group supervision from a world-renowned EMDR specialist on using EMDR in healing culturally based traumas. Our members have participated in several community outreach events and are part of a trauma recovery network. We have mobilized to assist the community during the August 12th, 2017 and the 2018 anniversary. We've also accompanied and provided support for the Justice for James Civil Rights Pilgrimage to Montgomery, Alabama. And finally, we participated in the 5th annual Women's Health Awareness Celebration. Thank you.
I just had a quick question. You talked about those 50 providers. It says Central to Virginia. Could you just give me a sense of the region that encompasses? Like
Let's see.
how you define that region, the Central Virginia region?
Central Virginia, does anyone, do you all have a better sense of that? I know it would include Charlottesville, but also the surrounding areas like Harrisonburg,
Okay.
Lynchburg,
Okay.
Petersburg, Richmond.
Thank you. I'm just trying to get a
Richmond.
scope of how broad that is.
Yeah,
Thank
it's
you.
pretty broad. Yeah.
Thank you.
Okay. Thank you.
Hi everyone, my name is Ulises Martinez. I'm here tonight to talk about Creciendo Juntos. Creciendo Juntos is a non-profit organization based here in Charlottesville, Virginia. Creciendo Juntos means growing together. It first started in 2005 as an effort of different community members who were concerned about how the Hispanic population was unable sometimes to access to different mental health services, and many of them to basic services. So they started creating awareness through workshops, through lectures, through partnering with other agencies to create and raise this awareness and the importance of providing services to this vulnerable population. Nowadays, Creciendo Juntos has a very, I would say, broad and interesting website. If you access to it, it's cjnetwork.org, and it helps you identify different providers or different resources that provide services in Spanish, which nowadays it's a very important I would say, option for those of us who work in the mental health field. Right now we have 3 main groups. One of them is Cultiva, which main mission is to provide information, help service providers in the community to build skills about how to better serve this vulnerable population, the Hispanic population, the Latin population. We usually have different workshops or different trainings along the year, at least 2 big trainings where we invite the whole or the different providers in the community. We also have the Bilingual Mental Health Therapist Group, which is a big effort that it started basically trying to gather all the different bilingual mental health providers in our community, which 10 years ago, as I've been told, it was probably just about 3, 5. Nowadays we have more than 17 different providers identified who work with different type of clients. We started our meetings on February 2017, and we've been meeting quarterly since that time. The goal for the next year is to meet monthly, so we can continue addressing and providing support and supervision to better serve our clients. The third group that we are holding is the Latinx Group. This is particularly, I would say, one of my favorite programs, especially because we invite to the whole Hispanic population to be part of these conversations about how to building skills, about how to better advocate for themselves. We help them build these capacity as a community to access not only services, but also to create this awareness in their own spaces. One of the particularities that I would like to address about this group is that members are can attend since they are 16, which is, I think, one of the most important parts of it, because it's a generation that it's learning how to find their voice and how to use it in a very positive way. They have done some activities such as wash cars, to get a fundraiser, to have these different events in the community that can start helping other members of the community to identify the importance of the Latin community here in our Charlottesville area. Any question?
Thank you.
Thank you.
Good evening. My name is Gene Cash. I am the CEO, owner of Counseling Alliance of Virginia. I'm a licensed clinical social worker in the state of Virginia and state of Ohio. I would like to say I appreciate the opportunity to come and speak to you guys. I came to Charlottesville in 2008, and it was definitely a new experience coming from Ohio. And as far as seeing, having the opportunity to speak to the city council around race relations and the impact on how I've seen Charlottesville grow as a community in regards to race and discrimination. I was like one of the only, no, I was one of 3 black therapists in this community that's what people told me when I came here. And I knew that something had to be different, something had to change. I had a hard time with Charlottesville City as far as interacting with professionals, community members, because I was seen as less than, or there wasn't that many of us around. I'm an avid member of the clinicians, the Central Virginia Clinicians of Color Network, and I am so proud of that group. I am so proud of the people who organized that group. To see approximately 50 people talking about race and race relations is essential, imperative, and important. Counseling Alliance Virginia has been around for about 7 years. We do focus on providing care to our Medicaid clients, our marginalized clients, and community-based services. We also focus on outpatient clinical services. I don't know how many people since August 12th said, "I'm so glad to see you." I'm so nice to have a black therapist in this community, because there's not that many. So to have the Central Virginia Network with their focus on training and really building capacity around racial diversity, so people can have an option in Charlottesville, is really nice to have. So after August 12th, we also have a Latino access program at Counseling Alliance Virginia, where we attempt to hire, train, and bring Latino clinicians, not just as mentors, not just as people who are paraprofessionals. We're talking about licensed clinical people. Counseling Alliance Virginia is focused on training licensed people. And my staff will hear me. I want you to be licensed. I don't want you to just be a paraprofessional who settles to be a mentor and to just provide those ancillary services. You are a clinician. So that's what our focus is the building capacity. And it's not only for just Latino, African American, but also for white clinicians. And this is where Dr. Hardy stepped into our lives, okay? A lot of people may not know him, but I went to a training. I knew him in Washington, D.C. at the Psychotherapy Networker. That's when he and I connected a long time ago. But one of his trainings was about walking beyond eggshells. Race inside and outside the therapy room. And that's when I learned a lot about myself as a clinician and how we tiptoed around race and how we wanted to keep the privileged comfortable, and we wanted to have, not we wanted to, but that's the way it happened. And the oppressed or the subjugated continue to be subjugated. So Dr. Hardy, after August 12th, I asked him to come to Charlottesville because I believe that we need to build the capacity for people to handle race, not culture. I'm not talking about cultural humility. I'm talking about race, awareness, and racial sensitivity is what needs to be on the table, and we need to be able to talk about it. So Dr. Cardi came in January last year, 2018. The response was excellent. We had over about approximately 150 clinicians and community members who attended those 2-day trainings. And I believe you were there, and we enjoyed having you. And the energy in the room was powerful. And the tears and the sadness and the stories were also even more powerful. And that's when Counseling Alliance Virginia made a commitment to make sure we bring him back every year, okay? And then I believe we initiated racial awareness support groups after that workshop, where we meet every other Tuesday since March of 2018. And we've built a nice group of, a lot of them are clinicians, and community members, where we have contextual conversations around race and around race and how we feel about our different perceptions, okay, and how we relate to each other. And that's been going on all year. And it's been a nice space for people to heal, to people talk about their challenges at Whole Foods, their challenges at my challenge is just shopping, just walking around gas stations, and being able to talk about the microaggressions that occur in our community. So the racial awareness support group has been great. Dr. Hardy is committed to coming back, and that's when we stepped in with the Women's Initiative, the City of Charlottesville, DHS, Department of Social Services, and the Mental Health Wellness Coalition. We all met, we've teamed up, and they made a commitment to bring Dr. Hardy back to the Charlottesville area to focus on talking about race and race relations. There's like 3 levels, there's more than 3 levels, but what we focus on is the task of the privilege, okay? What are the tenets that the task of the privilege need to do to help heal the racial trauma and the microaggressions that happen in our community? But the other big thing I believe that has to happen is the task of the subjugated, of the oppressed, and helping them heal and learning how to have, I would like to say, a path or a walkway on how to heal, because a lot of it is around the anger, frustrations, learned voicelessness, but helping Black people, people of color, learning how to navigate a way out and to have a voice. And just to be able to have contextual conversations. Sometimes when we talk about race, we move too fast. Sometimes we talk about anything that's uncomfortable, we move too fast. And Dr. Hardy is giving us a path and a vision and some tools to be able to have these conversations, not by yourself individually, not just white people over here or Black people over here, but having them both together, truly bringing diversity into the room. And the other commitment that we believed with this partnership is that it's not going to be an overnight thing. It's not just going to happen once in 2017. This needs to happen year after year after year. I lived in Charlottesville a little bit. I live in Richmond. We have the same issues, a little bit different. But the problem is we talk about it and then we move on. So I appreciate this time and allowing us to continue to bring this type of thinking and awakening to the Charlottesville area. So I think that's all I need to say. If you have any questions, I'll be happy to ask. Thank you.
Hi, good evening. My name is Lee Freilich. I'm a licensed clinical social worker in Charlottesville City. I've also lived in Charlottesville since 2004, so I've been here a long time. I have a private practice, and I've worked for the Women's Initiative as well, and they were gracious in helping me get started, a clinical consultation group for therapists and all healthcare providers and advocates within the community who provide care to trans and gender nonconforming people. I think before I say any more, I want to ask that we just take a moment of silence for Sage Smith, who was a Black trans woman who disappeared from our community on November 20th, 2012. Okay. If you don't know who Sage was, I encourage you to talk with me or find other information and help advocate for resources to be dedicated to help find her. She's still missing. My work with trans and gender nonconforming people has grown in the last few years as more and more people have been able to gain access to care at UVA. There's an adult transgender health clinic, and there's also a pediatric and young adult transgender health clinic. And there are numerous health inequities that transgender and gender expansive people face. There are more people in need of care in our community than 1 or 2 or 3 clinicians can provide care for, or than 1 or 2 clinics can offer care for. And so the consultation group exists to build capacity within our community by utilizing the specialized expertise of someone who's a nationally renowned expert in the field of transgender healthcare, who's also a licensed clinical social worker in New York. I guess just so that everyone understands and appreciates the desire or the dire need for services for these populations of folks who are gender expansive, I'm just going to share some data. In 2014, the UCLA Williams Institute of Law, drawing on findings from the National Transgender Discrimination Survey, found that trans and gender nonconforming people have lifetime suicide attempt rates of upwards of 41%. In the general US population, that rate is 4.6%. That is a shocking and appalling difference and disparity. And when you look further to see what data looks like for people who earn less than $10,000 in income, that rate goes up to 54%. For people who are Black and multiracial, that rate goes up to upwards of 54%. For people who are ages 18 to 24, it's 45%. In addition to lifetime prevalence of suicide attempts that's elevated, trans and gender expansive people are at greater risk of depression, anxiety, discrimination, refusal of care, incompetent care, and violence, sexual assault, physical violence, and emotional abuse. In another study that was published in 2016, and that was a sample of 300 Virginians that had completed the Virginia Trans Health Initiative Survey. 37% reported being attacked physically, and the average was close to 4 assaults. So we're talking multiple assaults. The thing that I see happening so much with trans and gender expansive people that come to see me for clinical care They don't have good access to primary medical care or specialized care. This is a highly specialized, cross-disciplinary area of practice where people are in need of good support from physicians and psychiatrists and psychologists and therapists. So for people who experience gender dysphoria, who are seeking medical interventions to help alleviate the stress and the minority stress that they experience from a disconnect between who they know themselves to be, the anatomy that they were born with, the sex they were assigned at birth. They are in need of access to hormones and surgical care. There are international guidelines that that drive surgeons and physicians' practice with folks who are seeking trans-affirming medical care and considerations. And those often require that people are under the care of a mental health professional at the same time that they are getting medical care. So with the 2 clinics that exist in our community, as well as the fact that more and more clinicians are signing on to come to the consultation group who are saying, yes, I have a client, or I have a family where someone just recently disclosed that they're transgender, or I'm working with a couple where one person in the couple is questioning their gender. There are innumerable ways in which better support is needed within our community for people to be able to access quality care, affordable care, and not only mental health care, but medical care as well. And so if there is opportunity for council to consider dedicating any amount of funding towards training, education, and medical and mental health care for trans and gender nonconforming people, particularly people who are uninsured, underinsured, and who are low income, I urge you to please consider dedicating funds in those ways.
Thank you.
Hi, my name is Karen Osterhaus, and I work at Region 10. And I'm just going to briefly talk about organizational assessments used for looking at health inequities. And we've been fortunate in our community to have the Coalition for Mental Health and Wellness Coalition working on researching health inequity assessments for us. And Rebecca Kindle has been key in doing this. And what she has recommended is the Bay Area, I don't want to get it wrong, Regional Health Inequities Initiative. And that is also the same organizational assessment that the Department of Behavioral Health and Developmental Services in Richmond is also using to look at their internal organization. And Region 10 has also chosen to use this organizational assessment to begin to look at inequities in our system of care. This is a very intensive organizational assessment. We're looking at beginning in the next year or two. It will take a long process of working with staff groups, working with our consumer groups, working with policies and procedures, and looking at all aspects of our organization to highlight and pinpoint and prioritize where our work needs to begin for looking at inequities within our system. And so this is a tool that Rebecca has vetted very well and is also recommending to other agencies that are within the coalition. It may not work for all of these agencies because a lot of our different coalition partners have smaller agencies than Region 10 does, but we will be looking at this full organizational assessment. And if Rebecca was here tonight, she'd have a lot more to say about it. Thank you.
Hi, I'm Molly Yates, and I'm with Region 10, and I direct an integrated care project there. And I want to talk about integrated care. About 4 years ago, Region 10, when we restructured the Preston building, brought in a primary care clinic, so there'd be a primary care doc on site and could serve people who are getting Region 10 services amongst other people in the community, and have more integrated approach so that there's more of a approach of looking at the whole person when people are getting care, and it also improves access, that when people are getting services at our building, they can also come in one stop, also see their primary care doc, and facilitate communication, so there's fewer gaps in holistic care. We were initially partnering with Centera about a year ago. We moved that partnership to the Neighborhood Family Health Center, which is across the street on Preston, and they're a full clinic, but now they have a full-time nurse practitioner who's in our building. Her name is Cinciana Bartzleski, and she's fully fluent in Spanish. They've been a fantastic partnership. We've both been thrilled because they're a federally qualified health center. So they work on a sliding scale. They have very low barriers to access. They're very welcoming. They have extended hours across the street. And so it's been just a great partnership. We have about 350 people who are served at Region 10 who are also served in the clinic. And then she also serves people in the community. So it's, again, very low barrier to access. And about 2 years ago, we received a SAMHSA grant called Primary and Behavioral Healthcare Integration Grant. It's a 4-year grant to help improve these systems of care so that there's better integration, better communication between primary and behavioral health care. And it also promotes wellness initiatives for people with serious mental illness to be encouraged to be more thoughtful about their self-care, to receive more preventative health care, to be more engaged with their primary care doctor so that they're more likely to manage their chronic conditions or emergent conditions more quickly. We offer multiple walking groups at different parts of the city to try to improve access, to help people engage. We've got chair yoga, we've got nutrition, we've got cooking classes, mindfulness. We run a chronic disease self-care management group that's a Stanford-based curriculum that addresses diabetes, and then a different one that's going to address chronic pain. And we're going to start that one in February. We've had a great response to that. We've got art for self-care. We usually have we have a quarterly luncheon to try to get feedback from participants on how we can improve. We not only serve Region 10 consumers, but we try to be available to anyone with a serious mental illness in the community, so they can be served by the Free Clinic or Northridge or anywhere place in town. So we're always trying to get ideas about how we can be more available outside in the community.
One of the other areas that folks were interested in that we wanted to highlight is the lack of psychiatrists in our area, and actually that's a nationwide shortage. So Region 10 is not alone in trying to find qualified psychiatrists to work in community behavioral health. The Merritt Hawkins Healthcare Staffing Survey in 2017 reflected an ongoing shortage for medical specialists, psychiatrists being second on the list in 2017. In 2005, psychiatry was number 13, and in 2013, number 4, and for the last 3 years, number 2. So you can see that the difficulty in finding psychiatrists is throughout our country. And factors that contribute to this shortage is the growing awareness of mental health problems and the slowly decreasing stigma associated with having mental health issues. Mental health providers are also reimbursed less than physical health providers. 60% of practicing psychiatrists are over the age of 55. Another factor is that baby boomers are growing at a rapid rate, and they have the highest healthcare needs, both physical and mental health care needs. And then, of course, there's burdensome documentation requirements in the mental health care field due to the requirements of Medicaid and Medicare and how those services need to be documented. At Region 10, we have, starting 10, 15 years ago, have looked at hiring not only psychiatrists, but also nurse practitioners. And at this point, we have, I think, more nurse practitioners than psychiatrists. I believe we have 5 nurse practitioners to 2 psychiatrists within our facility. And so we continue to experience a dearth of applications for not only psychiatrists, but for licensed clinical social workers and licensed clinicians across the board.
Thank you.
If you are looking on your agenda, you will see that I am not Erin Tucker. My name is Anna Mendez. I am the Executive Director at Partner for Mental Health. Erin regrets that she's had a personal matter that means she cannot be with us this evening, and she called and asked if I would speak on her behalf for just a moment. And I was quite honored that she called me, but I'm actually standing next to the real expert in peer support, so I'm very quickly going to sit down. You're welcome. But for those of you here who are not familiar with the concept of peer support, Virginia has recently created a certification process for individuals who are themselves in long-term recovery from either a mental health challenge or substance use disorder. On Our Own is an amazing resource here in Charlottesville. It's that house on 4th Street. And it is an organization that is all of its staff and all the board, right? And all of the board are people themselves in recovery. At Partner for Mental Health, we view On Our Own as an invaluable resource. So many of the people that we work with really feel most comfortable beginning their journey back into community integration, starting at the beautiful safe space that Erin and Cindy have created at On Our Own. At the recent opioid convening that the Community Mental Health and Wellness Coalition has put together, one of the substance use disorder physicians at UVA actually said that more than one of the patients that she works with has said that On Our Own actually saved their lives. So it is an amazing resource. It is a place where people can go and know that as long as they are willing to be working on their own recovery, it is a safe and welcoming place for them. And again, if Erin was here, she would do a much better job of describing this than I can, but I am honored that she asked me to speak on her behalf, and I'm now going to hand it over to Cindy, who will do a much better job than I.
That was very good. Thank you, Cindy Richardson. And as you heard, I come from work at and honored to be at On Our Own. I have been there for going on 10 years. On Our Own has been in existence in the city of Charlottesville for close to going on 28 years, which is longer than some marriages, I guess you can say. You know, it's really working. I'm going to tell you what On Our Own, what peer support is not. I'm a certified peer specialist. It is not clinical. It is not diagnosing. It is not telling you how you should feel. It tells you, it meets you with, tell me how that makes you feel. It gives you a balance. You know, sometimes we can feel, and that is someone suffering from a mental health or someone that is just walking down the street. We can feel that we are so different and we are so unique that no one can possibly understand what is going on in our head. And then you come into On Our Own and you hear your story. You not only hear it once, but you hear it twice. It is an honor to be in peer support because you not only give, I receive, we receive, you can receive as much as you give out. It certainly is reciprocal because it forces me to be humble. It forces me to remain grounded. It forces me to not look at what is going on, but how it went on. So a lot of times I can identify with that. And I find that peer support works because it allows someone to be themselves. They're comfortable, and we do it every day. I wish I can stand up here and tell you all of the success stories that I have seen, and if you think about it, the short time that I've been at On Our Own, they are miraculous, as you have heard. And that's why we definitely call it the Yellow House of Miracles, because it definitely happens in that house. And we're proud of it. And you know, and you think about peer support, well, sounds like you're just talking one-on-one with someone. Sounds like a conversation, but it's so much more than that. What it is I think the biggest thing is listening, something that I had to learn how to do. I was more of a wait for a response type person. I didn't hear what you said. And a lot of times it has taught us to, first of all, listen with our heart. And that resonates, and with the eyes. And we look in the eyes and you can hear someone's pain. And it may not get solved that day, and that's okay. It may not be solved that next week. The beauty, what we look for is when someone crosses that threshold the next day after we've given them an orientation or just a cup of coffee. But something happened when they were in that room that they realized, man, something is here. And like Anna said, it's work. It is work. Sometimes it's tear-breaking, it's heartbreaking work, because we have to be like an onion and peel back layers of who we are. And sometimes that's not very comfortable. But the growth is so much worth it. And so if I can just hold your hand until you get to that part, through peer support, through one-on-one. And how we do it, it's not all talk, it's groups, because we all realize that something happened to us when we were growing up, or just like yesterday, that gave us this trauma. Something traumatized us so much that I don't want to talk about it, and then we stuff it, and then it just grows and grows. So we allow things to we tell them, just throw it out on the floor. Just throw it out there. Don't think about it. Just throw it and leave it there if you can. Now, a lot of times it gets picked back up because I'm not ready to get rid of it. Sometimes we can be real comfortable in our misery, but On Our Own holds you. Peer support guides you through it. You know, when I first started, and I was asked by my previous executive director, would you like to be a peer support specialist? I didn't know what it was, and you probably didn't know what it was either. But it was a chance for a career, so I'm like, okay, no problem. How do I do that? And then I go through this series of classes and everything. So I had no idea. Just like you had no idea about this. On Our Own was not really on the map. And as I said, we've been around a while, but between Aaron and I mean, we show up. We want you to know what On Our Own is. And now, if I say On Our Own, a lot of times people go, oh, I know that yellow house. I've been there before, or I've seen it, or I've rode by that house. I always wondered what went on in there. And now you know what goes on in there. And it is a mission that we have to let everyone know. There are a lot of family members I would love to bring in On Our Own. Just come to work with me one day and, get a little support, get a little peer support. But we all know someone that can use an On Our Own day, week, year, whatever, whatever it takes. So come on by, get a cup of coffee. Thanks.
Thank you.
I'm still Anna Mendez. I'm still the Executive Director of Partner for Mental Health. I want to start by saying how grateful I am that City Council has convened this work group meeting. I am grateful, Mayor Walker, that you are here, Councilperson Gavlin and Heather, thank you for coming to the first graduation of the Therapeutic Docket. It's good to see you. Partner for Mental Health is the Central Virginia affiliate of Mental Health America. We are also the lead affiliate of Mental Health America of Virginia. We are the chair of the Mental Health America of Virginia Board of Directors and the statewide public policy organization. In that realm, we actually do a lot of advocacy and lobbying in Richmond. And in that work, I actually work quite closely, fairly often with Mira Signer, and I will tell her that I noticed her brother was not here this evening. But locally, here in Charlottesville, what Partner for Mental Health is known for, we view ourselves as the independent broker of mental health services and supports. And what that means practically is someone calls us because either they or someone they care about is experiencing a mental health challenge and they don't know what to do. They don't know, there are hundreds of licensed therapists here in Charlottesville. Per capita, we have more therapists in Charlottesville than anywhere else in the Commonwealth. And you're facing this crisis for the first time, possibly. You don't know, is the Women's Initiative the best fit for what you need? Can Region 10 offer what you need? What is peer support and what is this beautiful yellow house of miracles and how do I, and how do I get there? My staff are really experts in helping people figure out what is going to be the right level of care, the right provider, and the right fit the first time. Interestingly, for about half of the roughly 300 people that we serve every year, while they have some type of mental health challenge, they are not interested or are not looking for clinical care. What they have identified as being the biggest barrier to their success and stability in our community are the social determinants of health that probably most of us in this room take for granted. So things like stable housing, employment, childcare, so that you can get to your job, transportation, things like that. And what makes Partner for Mental Health unique is that you never have to talk to us about your mental health diagnosis. You can simply come to us and say, I need help finding housing. I need help figuring out how to manage my diabetes. I need help figuring out what's going on at the bank that my checks are always bouncing. You never have to be willing to engage about what your diagnosis is in order to receive support at Partner for Mental Health. And that is something Roxanne and the rest of my staff understand that people come to us at different levels of readiness to engage around what their diagnosis is, and there's no prerequisite about being ready or willing to take medication or even to go to therapy in order to get support and assistance from us. Again, I'm really grateful that City Council is interested in starting this conversation. I do hope very much that this is just the start of the conversation about how the service system in Charlottesville can be better reflective of everyone in Charlottesville and best meet everyone's needs. So thank you. Thank you. Yeah,
I have
Heather.
a question about how do you raise awareness in the community so that people know to come to you for these services or recommend others to you for these services?
Yes. So so historically, the majority of our referrals have come from 50% previous recipients of support from Partner for Mental Health, kind of like word of mouth. Roxanne was able to work a miracle for someone in jail, and for the next week, our phone did not stop ringing with jail calls. So about 50% really just word of mouth. 25% have historically been referrals from clinicians who say, I am a great trauma therapist, but while this person is still living in an unsafe situation, I can do all the trauma therapy in the world, but it's not going to be particularly effective. And then the other 25% have come from social service agencies like a soup kitchen or Potchum, someone saying, I see this person over and over again, and it's clear that part of the reason they're struggling is because there's a mental health thing that's not being addressed. That's kind of how it's worked historically. Right now, we are very fortunate that this fiscal year, we have entered into three new contracts for service. So one with the Therapeutic Docket, one with the UVA health system, and then one with ACRJ. And so right now we have unfortunately, we have very defined pipelines right now for how we can receive referrals. Having said that, we're also very bad at saying no, and we like to help people. So even if someone doesn't beautifully fit into one of those categories, we're not going to turn them away. We also won't turn away any additional funds so that we can continue to provide those services and not have to turn people away.
And for both Partners for Mental Health and on our own, I'm just curious, how are those funded primarily?
I would have to let Cindy talk about on our own. I can say Partner for Mental Health, we are 100% privately funded through just private philanthropy. People here in Charlottesville who believe in what we're doing. Our services are 100% free to service recipients and always will be. We believe that even a $5 copay, we don't bill insurance, so that's not language we use, but even a $5 cost to meet with Roxanne would be a barrier that some people would not, that would prevent some people from feeling like they could come to us. So 100% private philanthropy. And Cindy, if you want to talk about how On Our Own is funded, I can't answer that question.
Yeah, and we can just, I
Okay.
probably have that question across the board, so
Okay.
we can wait till the
Okay.
end. Thank you.
Hello, everyone.
Hello.
Thank you guys for allowing me the opportunity to come up here and talk about my program. My name is Deidre Creasy. I work for Region 10, and I supervise a program called Community-Based Recovery Support Services. What's unique about that program is that it nurtures self-empowerment, choice, and it also is in the 7 public housing communities as well as Friendship Court. Historically, the program was there probably about a year to a year and a half before I took it over. But one of the first things that I learned and that I wanted to make sure that everyone heard tonight is that when working with anyone in the community, it is essential that rapport is built and that you're trustworthy. Once again, when working with anyone in the community, it is essential that a rapport is built and that you show community members that you are trustworthy. So the services that we provide in the 7 public housing communities are peer support, wellness activities. We also have an advisory committee comprised of different organizations: FAR, Human Rights, CHIP, PACE, She Shelter for Help in Emergency, just to name a few, Sarah, where we all have a quilt philosophy. We outreach the communities, and if it's a service that Region 10 can't provide, maybe it's something that they need from Sarah, or maybe CHIP can help, just to make sure that we're taking care of the community as a whole. We also host an annual CRANU event where the advisory committee, as well as our CRANU team members, and some people are probably saying, what's CRANU? CRANU is Community Recovery for All Neighborhoods United. And what makes that so unique is that the residents from the public housing community came up with the name. The residents from the public housing community helped the advisory committee to drive what that event will look like, and also what are the other needed services they want directly in their community. Also the logo, I don't have a t-shirt tonight, but some of you guys are familiar with the logo with the hands, was also chosen by members of the CRANU team who are residents of public housing, who then some of them go on to be employed with us. So that's kind of what makes our program unique. We also worked on the Black Mental Health Matters event with West Bellamy at the Jefferson School, where we had Darnell Walker come and screen his film. And basically our goal as a team and as a committee is to make sure that we knock down some of those barriers that are stopping residents from being able to access services. Once again, I just want to say that establishing rapport and being trustworthy is essential to working with individuals in the community. I'm thankful for the communities for allowing our programs to come in and help. We do outreach, door-to-door, flyers. Our outreach looks different from a lot of people's outreach. We believe that even having a simple conversation or sitting on someone's stoop just to talk to them is good enough. Just to let them know that we're there, and let them know the services we provide, but that we're not looking for anything. We just want to make sure that they have what they need and access to exactly what they need. And in closing, again, I just want to emphasize that building a rapport and being trustworthy with the community is essential. So thank you.
Thank you.
Good evening. I want to thank Council 2 for having this work group. And I want to thank myself because I'm the one who came to Council asking the questions that brought forth this work group. So I'm Myra, in case you didn't know. And the credentials that I will bring forth is that I am a Charlottesville native. I've lived here my whole life. So has every generation of my family, dating back to the 1800s when my family ancestors were enslaved at Monticello. I will also say that I have struggled with mental illness myself since the age of 10, and probably every year since then, I have been hospitalized anywhere from like 3 to 5 times. That's a whole lot of hospitalizations. So I'm speaking to you from that experience, and I was asked to speak on stigma reduction. So what I want to say is going to relate specifically to how I feel it's been for me as a person of color dealing with stigma, because that's the skin that I'm in. I think that ever since I can remember, it has been abundantly clear to me, even from a young child, that mental illness and mental health in the African American community is highly stigmatized, and it's something that isn't always talked about in the sense of open conversations. I think that's changing a little bit more and more, but I think that there is still so much to be done. I remember when I first, well, actually when I was in college, and a lot of my friends were trying to convince me that I really didn't need to take medication, that I didn't really need to go to, a doctor. I was just hitting a rough path, and it was clear to me that I was dealing with serious symptoms, but the people around me, all of my friends who were African American, were giving me the message that, it wasn't that serious. And I think that's one of the things that relates to stigma, specifically in the African American community, because although African Americans are more prevalent to experience mental illness, they're less likely to seek help. And I think that directly relates to a lot of the stigma. I personally think that some of the stigma has to do with psychiatry in general, and the fact that it is deeply rooted in European traditions, and that seeking mental health treatment, particularly in the African American community, is often something that white people do and not Black people. And so I feel like I personally have had to overcome a lot of barriers as it related to stigma. I think that mental illness is also something that in the African American community, if you're strong-willed, then that's not something that you would have to experience. And I think that goes, actually, my opinion, after going to Africa this summer, all the way back to our roots about being strong people, and that is what has kept generations going. But I think at the same time, it's something that has pulled us back as it relates to mental illness. I also think that faith, and that's something that's usually not talked about in traditional therapy services, but faith is something that we as African Americans draw on a whole lot. And a lot of people think, well, if you just draw on your faith, you don't need those things. You don't need medication, you don't need this, you don't need that. So there's also a stigma behind that as far as seeking treatment when it has to do with faith. I think that to reduce the stigma, because that's what I'm supposed to be talking about, I think as it relates to the African American community, I think that there has to be a two-pronged approach, one that focuses on changing perceptions and making culturally competent care more accessible. First, I think it's important to acknowledge how racial and economic oppression can affect the psyche of African Americans, and so that they don't feel further marginalized by being diagnosed as crazy, because that's something also in the African American community, you don't want to be crazy, but I'm so over that. And I think that a trauma-based approach to African American mental health care will take away the blame and the perception of mental illness as a sign of weakness. I also think that there should be especially more of a focus on mental wellness and not mental illness, and that can give more people a sense of control and help to build emotional resilience. Mental health is also marginalized in health services, and it is not always a standard component of primary care. There also needs to be explicit efforts to encourage mental health discussions among African Americans through culturally specific information. Someone had already stated that earlier. My organization, Brave Souls on Fire, has been making efforts over the past 6 months to start to open the conversation up about mental health, specifically in the African American community. And on the services side, I think African Americans need access to culturally competent practitioners who more understand our beliefs, our values, our experiences of racism. And I'll tell you this quick story, not exactly related to mental illness, but I had to attend a training down in Richmond at a gym down there. And here in Charlottesville, I go to ACAC. But this gym, I didn't know until I got there, was a Black-owned gym. And so when I came in, I remember hearing the song that was playing, and I was like, gee, I never have heard this song in a gym before, you know, and everyone there was and the whole environment was different because it was a gym that mostly people of color came to, from the images on the wall to the way that people greet, to the way that people engage. In this gym, it was completely different. And I got a completely different feel about being there, and I felt very, very comfortable, even though this was my first time visiting. So much so that I came back and told my mom I wanted to join the gym in Richmond. She thought I was crazy. But the point is that, and this is where I'm drawn to, because I think ultimately when you talk about reducing stigma, specifically in the African American community, and more specifically after a lot of the incidents that have happened here, I think that beyond talking in this work group, that council, coalitions, organizations need to seriously consider an idea that was birthed probably 18, 19 years ago, which was the Sankofa Center, a mental health center specifically for African Americans. Now, I submitted a FOIA request to Region 10 because they were the people who initiated this, to see exactly why it was that this Sankofa Center did not continue. And the reason, which is clearly stated in their minutes, did not have anything to do with people not attending, not African Americans coming out. It was a funding issue and an issue that the staff that they had moved away. They suspended the center and never went back to that. Now, I think I can say from my own experience, it is very, very different when you come into a place and you feel welcome. You don't have to spend 15 minutes of your session trying to set up the culture component before you can explain exactly what it is. But more importantly, most importantly, if you have any type of trauma that is rooted in race, it is very hard to go and speak to someone about that trauma who is the same color as the person who caused the trauma in the first place. So I feel like moving forward, as I've already stated, I would like to suggest that there be a subgroup or whatever planning group to look at bringing something like that, because I feel like if we're talking about healing, if we're talking about reducing stigma, if we're talking about bringing more people into services, we need our own space. You can't heal in a space that seems like it's the same space that is hurting you. We need a space to feel vulnerable. We need a space to feel heard. We need a space where people look like us and understand us, and we don't have to go through all of this setting up and wondering, you know, having all of these judgments and all these things like that. So that is what I have to say, because I think that at the end of the day, it's not enough to put one or two Black therapists in this organization or that organization and feel like you're diverse. If there's a truly commitment to diversity, then I feel like there should be this option for people who feel that way. If you look at any African American doctor in town, you will know that most of the people that go to them are African American, because that's what they feel comfortable doing. So that's pretty much all that I have to say. Thank you for allowing me the space.
Thank you.
Hi, I'm Susan Morrow. I'm the drug court coordinator here for the Charlottesville Albemarle Drug Treatment Court. I also oversee the Therapeutic Docket program, and like several other people here today, I'm on the advisory board for that program.
Hello, I'm Ashley Bowles. I'm the Therapeutic Docket Specialist at OAR.
So we're gonna kind of tag team this. change it up a bit. So first question people usually ask is, what is a therapeutic docket? The model of a therapeutic docket is very similar to the drug court model. It's a voluntary alternative to incarceration program for individuals with serious mental illness who are charged with misdemeanors or some low-level felonies in Charlottesville or Albemarle. The program lasts 6 months to a year.
Participants are required to follow individualized treatment plans to address mental health, substance abuse, and their criminogenic needs. They are closely supervised by the therapeutic docket judge throughout their participation and can receive sanctions or incentives depending on their level of compliance with their treatment plans. Upon completion of the program, their charges are dismissed. My turn again. Okay. I briefly wanted to go over the goals of the therapeutic docket. Number one, to reduce the number of individuals with serious mental illness who are held in jail. Number two, to improve linkage to community mental health services. Number three, to reduce recidivism and contact with police. Number four, to increase the overall well-being of participants and graduates, for example, with housing stability, employment, personal and family relationships, etc. And number five, to promote communication and effective use of resources among community and criminal justice agencies.
I'm going to add that Roxanne is a huge part of us being able to do number four, which is to help people increase their overall well-being. She spends a lot of time with our participants. So why do we need a therapeutic docket here in Charlottesville? According to a study by the UVA Department of Systems Engineering capstone team, on average, 1 in 3 individuals incarcerated at ACRJ, the jail, on any given day meets the screening criteria for mental illness evaluation. At the jail, they do a brief mental health screen, which is a validated instrument, and so 1 in 3 of those people scores as needing additional evaluation for serious mental illness. On average, 1 person per day is released from the jail who, based on their screening score, could benefit from mental health follow-up in the community. It is estimated that more than 1/2 of those individuals return to the Region 10 catchment area but do not receive services at Region 10.
The UVA study also clearly shows that those who meet the screening criteria are more likely to return to custody due to either a probation violation or new charges. About 1/2 of them are misdemeanors. We placed on your desk a copy of our one-pager. It outlines those who are eligible, how those can be referred, and just a quick overview of the program. We also put on the back of back here on the table a copy if those of you all who would want some. And thank you to those of you who came out to our first graduation. It really meant a lot, and just thank you for your time.
And now, or something. So while we're coming back to life here, I'm going to have to log in. There we go. So I'm Denise Bonds. I'm the health director for the Thomas Jefferson Health District, and I'm going to actually stand over here so I can see what I'm talking about. I was asked to come here tonight to talk about harm reduction, and I'm delighted to be here actually with all of these great individuals from the community who really do all of the fabulous work that keeps our citizens healthy. So harm reduction broadly is practical strategies and ideas aimed at reducing negative consequences associated with drug use. A few years ago, the legislative body of the state of Virginia passed a law that allows harm reduction here in the state of Virginia. And the rationale behind that was really these numbers here. So this is the increase in opioid overdoses by year of death from 2007 to 2016. And this is for the entire state of Virginia. And you can see that there's been a pretty dramatic rise starting in about 2010. You read stories all the time about entire cities being devastated by opioid overdoses. We certainly have had significant problems here in the state of Virginia, but as I'll show you, it's somewhat patchy. So harm reduction in Virginia, as passed by the legislature, had three objectives. The first was to reduce the spread of HIV, hepatitis, and other bloodborne diseases. The second was to reduce the transmission of bloodborne diseases through needle stick injury. And then the third was to provide information to individuals who inject drugs regarding recovery treatment services. And so, as defined by the law here, harm reduction could include the provision of sterile hypodermic needles and syringes, disposal of used hypodermic needles and syringes, and then typically includes provision of some sort of clean supplies. So it might include alcohol wipes, caps for mixing drugs in, clean water, so that individuals aren't reusing other people's rigs, as they're often known. To have a harm reduction program, the law is pretty clear. It says that, first of all, there must be a declared public health emergency. And the previous health commissioner, Dr. Marissa Levine, actually did declare that public health emergency, and we're still operating under it with our new health commissioner, Dr. Norm Oliver, who is actually from this community as a coincidental. And then the second is that the Virginia Department of Health had to establish criteria that indicated an elevated risk level. And these are all of the different factors that could go into that formula as it was. So looking at HIV and hepatitis, looking at drug overdose, poverty level, unemployment level, prescription opioid volume, the potential to be able to refer people to medication-assisted treatment, and on and on. So it didn't state exactly how that elevated risk would be determined. It just listed all of these various criteria that could be included as part of that. And so what the state of Virginia, the Virginia Department of Health did at the state level was come up with a formula looking at the rates of many of these factors in the community and also looking at the absolute raw numbers of cases. And so they tried to make it as objective as possible and came up with this map. And the blue counties on the map are those counties that met the criteria as established by VDH to be able to institute a harm reduction program as defined by the law, which is essentially a needle exchange program. And you'll notice that where we sit is not blue. So in fact, by the formula, we do not meet any of the criteria in the city of Charlottesville and really anywhere in the district to have a harm reduction program that includes a needle exchange. And I'm just going to show you just a couple of slides of data, and then I'll talk about what we are doing to reduce harm here. So the first thing is overdose deaths. This is by prescription opioids, and it's per 100,000 individuals. And we don't actually have 100,000 people who live here in the city of Charlottesville. You'll all have figured that out. But this is all normalized so that we have common metrics to compare across for cities. So blue is our district as a whole. The orange is Charlottesville. And the green is the state opioid rate. And you can see the city of Charlottesville, in fact, didn't have any prescription opioid deaths from the medical examiner. So these are ones that we're aware of in 2017, and is generally sort of above the district level if you look over time, but below the state level. We can also look at heroin and fentanyl deaths, and again, this comes from our medical examiner, again, normalized per 100,000. Again, the city of Charlottesville lives somewhere in between the state and the district as a whole. So that certainly doesn't exceed the state rates, but is greater than our general district. Every month, I get a list, and I'm happy to share with anybody that wants this, the number of ED visits for unintentional opioid overdose that hit our hospital EDs in our area. I put Charlottesville here at the top. If there's a little asterisk, that means that there's less than 5 cases for that month, and they don't report them out for privacy reasons. And you can see that Charlottesville tends to bounce around. Typically, it's under 5 cases, but we have had as many as 10 in the month of September. It's hard to compare across the district. Our rates are probably about the same as they are in Albemarle, and probably a little higher than most of our other localities, with the exception perhaps of Louisa. The rate is a little higher than the Virginia state rates, often. The CDC collects prescription rates by locality, and I have this, and you can go and look it up and see what your city prescribes. I've put in bold 2. Charlottesville is the orange line here, and the red line, sorry, that was a bad choice of colors, thinking about it, is the state of Virginia. The state of Virginia is generally, over the last few years, been a little higher. Here's the state, here's Charlottesville right here. Generally overall, the prescription rate for opioids is tailoring off, and that's a great thing as we become more aware of the problems of opioids in our community. It's certainly not at 0, and probably shouldn't be at 0, because opioids are a valid drug to prescribe for a variety of conditions. But you can see these are the number of filled prescriptions per 100 individuals. Finally, HIV and hepatitis rates figure prominently in whether or not you qualify to have a harm reduction. The dotted lines here are the hepatitis C. Again, green is the state. Orange is Charlottesville, and blue is the district as a whole. And you can see for hepatitis C, we in fact have fairly low rates. The solid lines are HIV, and our HIV rates in general now in 2017 are pretty low and really track right along with the state, and maybe slightly less than the state. So we don't have huge disease rates in our area. So all of that means that we don't qualify for a needle exchange program. And I'll just say anecdotally that there's one functioning in the southern tip of Virginia, and I think that the one in the Richmond area is opening or opened. If it opened, it's just opened. It's pretty challenging to get a needle exchange program open in the state of Virginia, because you have to not only qualify, the government has to sign off, the local government and the local police force have to sign off, and you have to submit a safety plan and a disposal plan for all of the needles that you're taking in. It's a fairly laborious process. It's not easy. It took about a year, I think, to get the first program up and running. So all that to say, we actually do a lot of harm reduction here in this community. We, at the health department, provide naloxone Narcan, which is an overdose recovery therapy. It's free. You can come and take a short class and walk out with your Narcan in your hand. Revive classes are taught at Region 10, and they are the Revive trainer for our area. We have pretty good access to medically assisted treatment. Last I heard, Region 10 still had slots available, and they're nodding their heads yes. There's access to counseling here. We've heard about lots of great accesses to counseling in our community, and all of these will reduce harm. We do testing for HIV and hepatitis. You can come to the health department. We'll apply a sliding scale, so it may actually be free for you. If you want it in the community, we have a testing staff member who will come out to any community event and do testing anywhere for both HIV and hepatitis. And we'll provide condoms for free, which is not listed here, but another great harm reduction. The health department does offer a pre-exposure prophylaxis clinic for people who are at risk of HIV. So that is taking a daily medication to lower your risk, either because you are in a partner with somebody who has HIV or because you might be an injection drug user. There's no cost for that right now. The medication is free and all of the services and testing are free at the health department. And then finally, we will do low-cost vaccination for hepatitis anytime people want it. We have vaccination clinics 2 days a week, and they can just walk in, and we're happy to provide it. So the community actually does, these are just fairly health-centric ones, but actually does a lot of harm reduction in our area. Finally, I've given here, this is where the data's at if you're interested in finding out more about your community, playing with the data in other ways. There is the drug overdose surveillance, that's the ED visits. There's a lot of additional data that's collected that we received. Again, anyone can go to that website. There is a opioid data dashboard, that's the last one. And then you can get other information about the harm reduction program in the middle one. So happy to answer any questions about that.
Can I come back up to the mic? Is that all right, Khaki? All right.
It's not up to me, but it's absolutely
okay. All right. Thank you. I want to thank Denise and the health department for really showcasing all the harm reduction around opioids here in Charlottesville and across Virginia. I am so grateful that this is at a really awkward height. I'm going to follow Dr. Bonds. This is so much better. Should have done this earlier. I am really grateful that we as a community understand that the appropriate response to opioid addiction is a health intervention model rather than a criminal justice model. And in a forum about equity issues around mental health, I'm just going to come out and say it. It's because opioid use is a white problem. We as a community have responded very differently to the opioid epidemic than we have had to other diseases of addiction. Actually, the reason that opioid use disorder is a white problem is based in systemic racism itself, which is that physicians are much less likely to write opioid prescriptions for people of color, even when they are medically necessary and appropriate. And that has to do with the systemic racism around people of color are going to be more likely to abuse these or sell these. So actually, because of that racism, there's actually been a bit of a protective factor in the African American community, which is a really sad state of affairs. The one thing I am hoping for the time here in Charlottesville and in Virginia, where we are able to meet any disease of addiction with the same framework that this is a health issue and not a criminal justice issue. I would say here, I would just say at Partner for Mental Health, the issue that we continue to see over and over again in terms of causing low quality of life and disability and unemployment and criminal justice system involvement is our rate of alcohol abuse here in Charlottesville, which is significantly higher, orders of magnitude higher than opioid abuse here in Charlottesville. Alcohol use disorder is the biggest driver. I wish Neil Goodlow was here from our criminal justice planner, because he's got beautiful data that shows that alcohol use disorder is the driving factor in return to custody events for people who have previously been involved in the criminal justice system. It is the largest driver of bed days, both at ACRJ and at the UVA emergency department. So I guess I don't want to make it sound that I'm not very concerned about people who are addicted to either prescription opioids or heroin. I just, in a forum that is framed around equity, around mental health, I just think we would be really remiss not to address this issue. So thank you for letting me take the mic again. And I will now sit down and be quiet.
Thank you. Okay. You're up. The only thing I wanted to just identify is that that council has asked me to come back in January to talk about peer support around the issue of reentry, and it may be that peer support around mental health and substance abuse around behavioral health in general would be an appropriate addition to that sort of assignment, and so just something for you all to consider.
I'm just hearing from so many different groups, and similar when we had the other work session, and thank you all for coming and giving of your time and sharing your experiences. There's obviously still some areas that need greater support, but just in terms of how different organizations work together, I heard a little bit of that from a couple of the speakers, but could you kind of just give me a little more clarity around how like the infrastructure of all these things work together to ensure that we are really partnering effectively to best meet the needs of the community? Because just so there's not overlap, but it's really just a partnership. I'm just trying to understand how that plays
Sure.
out.
I think that there's a number of folks in the audience who can speak to this as well. I would say that the coalition is doing a lot of work around strategic engagement and long-term planning for the community. And so some of that is role identification, like you all do this kind of thing and we do this kind of thing, and together we're going to try to make this big goal happen, which is new, right? I mean, I think a lot of agencies, particularly small agencies, are largely funded with private philanthropy, have to be focused on their day-to-day survival. So the idea of sort of throwing in with a group of other folks and a collective sort of goal can be really risky. But the coalition is really doing a good job, I think, bringing all those folks together around these big strategic goals. I also think we've heard that while there may be multiple agencies doing similar things, we've also heard the need for very targeted, specific services for folks. And so while it may look like we have multiple agencies doing the same kind of thing, this is a community that might need all of that, right? We've talked about, Myra very eloquently talked about the need for very culturally specific services for folks. And so I think however those programs emerge, whether they're sort of incubated like at the Women's Initiative or in other places, that there's some form of support for them, even though it may look like there's multiple agencies doing the same kind of thing. And so that coordination, I think, is largely through sort of shared experience and saying, we're both doing this similar kinds of work, and so we're going to share resources and join networks together to make sure we're benefiting from each other's wisdom. I think the two biggest providers in town, and actually Tom von Hemert wrote some emails sort of identifying this, are the jail in terms of being a de facto provider around mental health services, and then UVA. And so There's a lot of coordinating efforts with UVA through all kinds of efforts, including with the coalition, to try to do a better job connecting with the sort of largest healthcare and integrated healthcare provider. Not always easy, so maybe somebody in the audience can speak to some of that.
But clearly there still are some gaps with some of those targeted groups, obviously, including our African American community, as well as what Lee brought up with the transgender and gender nonconforming community. So I guess what is the way that the coalition can kind of help to target into those areas where there's still those gaps?
I think one of the things that the coalition is doing right now is really promoting this use of the organizational equity assessments to make sure that each individual organization that already exists understands how it can best reflect the needs of the community, and also, as a result, identify big gaps in the community, because there's no agency that's addressing them adequately. So I think that's one major way. That I think certainly what you're seeing is more gaps than overlap in terms of the system of care.
And so that assessment, is that, Karen, could you just clarify the time frame?
Oh, well, there's different portions that
Okay.
people can use of it.
Do you mind just talking in the microphone only, because that's how people at home hear us? Thank you.
Do people want to hear from you, Karen?
Yeah. There's different portions of it. I know the Department of Behavioral Health has modified it a bit. I know Rebecca's looking at different ways to modify it for smaller agencies. Region 10's looking at doing the whole big thing. And so for us, we're looking at starting it probably in the next year, because we're in the midst of our strategic planning year. And so that's going to be one of the objectives of our strategic plan. And then we'll move into the organizational assessment. And how long that is, I really don't know how long that'll be. But it's a fairly significant assessment process with a lot of different, modes working, whether, like I said before, evaluating your policies and procedures, evaluating your hiring practices, meeting with staff, meeting with your consumers, etc. So there's a lot of pieces to work. I can get Rebecca to send you the links for this assessment so that you can dive in as deep or, not as you want.
And who all is participating in that assessment? Like what organizations?
I don't really know. I know that one particularly is Region 10 is
Okay, so
using this
it's
sort of
unique
the
to them.
full-scale
Okay.
bar high
Okay.
assessment. I think that there are other organizations that are using smaller, either hybrids or different forms of that. But certainly there's a big push on the part of the coalition to support, either through technical assistance or just sort of some nudging, to get organizations to assess themselves around organizational equity.
Khaki, I have a request then. So usually where there are service gaps, there are funding gaps. So would it be possible come January that when you present to us that you begin to give us as a council an indication of where those funding gaps might be to help close those service gaps?
I think everybody in the community will return that phone call.
Well, I mean, again, within reason, it is budget season as well, but it does seem like an abundance of resources here in the community. But there does also seem to be cracks in the system, and so, there's private philanthropy, there's other funding organizations in the community, but where those gaps exist, the city government is compelled to look at that as well.
Sure.
Okay. Are there any other comments? Is there anyone that would like to speak from the public or didn't get a chance?
Good evening. My name is Tom Van Hemert. I work as the coordinator for the Thomas Jefferson Area CIT Crisis Intervention Team. I'm housed with the Charlottesville Police Department and also work out of the Region 10 office. I work for the largest CIT program in the state. I cover 9 jurisdictions, the city, the county, plus all the other rural jurisdictions and some other rural jurisdictions outside those regions, outside of Region 10. CIT is a collaboration, it's a team collaboration of bringing the mental health and the law enforcement and the medical systems working together. I wanted to emphasize sort of 3 800-pound gorillas in the room, which have been brought up this evening. One is about the jail. So the jail is our largest mental health agency in our locality. It's running approximately at 140% over its rated capacity. That number, to be honest with you, is terrific because less than 6 years ago, it was at 170% over its rated capacity. And CIT, due to the training and the work, has reduced the average daily population by 100, saving the city hundreds of thousands of dollars a year, and also improving the health and the recovery for people with severe or mental illnesses from going into the criminal justice system. The second 800-pound gorilla in the room is UVA Hospital. It's currently running 300% over its rated capacity. If you go into the emergency department, 1 out of 3 patients are now being seen in the hallways. If you look in the hallways, there are tape marks on the floor that will mark out a room. Of all the rooms in the entire emergency department, there's only 1 psych behavioral health room. And thanks to CIT, we got it funded without any city funds, without any city taxes, through state and private donations for that room to be established and also staffed. It's staffed by law enforcement, by mental health practitioners from Region 10, and I'm very proud to say that it's also staffed by 3 peer support specialists. And I give special thanks to On Our Own and to Sydney Richardson for training and mentoring them so they can help not just the person that is in crisis that is brought in, but also helping the family members. The third gorilla in the room, and I give credit to Ms. Anderson for bringing it up, is about stigma. And I think stigma is a politically correct term. The real word for stigma is fear. And we talk about the stigma is really the fear, and when we fear something, we don't talk about it, it's not part of our dinner conversation, it's not brought forth. So I have just huge admiration for you, city council members and staff, to bring up the fear of what is being brought up this evening and by the collaboration that's being brought through this conversation. One of the takeaways that I would like to add towards the fear reduction, the stigma reduction, is that we do quite a bit of trainings both in the schools, Region 10, social services with different faith organizations, is an exercise called Hearing Voices, where you will actually experience auditory delusions that was put together by a clinical psychiatrist who has auditory schizophrenia. And it talks about, and you actually experience those symptoms. And then we talk about the issues of stigma and how it can be reduced, or the fear can be reduced. So again, I want to say thank you and for your support for CIT and for the collaboration here. The most important part about CIT is the teamwork, and probably is the most collaborative effort here, because most of the people that are in this room are part of the CIT program, where we work with people that are in crisis or that are need help. And then the other part is, even more importantly, is that we're looking at the system and how we can try to reduce people from going into the criminal justice system, into the medical system, and how we can help people through that. Main concern, 2 parts that have not been addressed this evening. One is about the elderly. A lot of the nursing homes are using the ECO process to get rid of their quote-unquote problem children and putting them through the emergency department. And we've been working with a better system, working with our magistrate system to address that. The other part is for our kids, for our youth. There's only 1 state mental health hospital in the entire state that now helps with kids. And we've had kids in our emergency department that have had to be stabilized, not even stabilized, be housed, quarantined for 3 or 4 days because of a lack of mental health hospital beds. And so I think it's incredible that there's not a single residential mental health facility here in our own region for that. So again, a lot of gaps, but I think there's a tremendous amount of success that has happened due to the success and the teamwork of the CIT program. Thank you.
I have a quick question. Well, try to be quick, but can some of you talk to, oh, you can, it was fine, not necessarily for you. But can some of you speak to what you're doing to get client feedback on the services that you all are providing? So I'm just interested from an organizational standpoint. I mean, we usually think that we're doing well, but how are your clients telling you whether you're doing well or not, or what needs to be done differently?
I can speak to that for the Women's Initiative.
Could you? Mm-hmm.
So each time someone comes in for individual counseling, they're filling out a very brief instrument around how they are doing. It's called the outcome rating scale, and each week we're tracking whether that's improving or not improving, and that's part of the ongoing review of whether this is working. So that's the very first thing, is it's an ongoing feedback loop with your clinician. We also have a confidential client satisfaction survey. If someone has something to say that's negative, positive, or whatever, that's something that can be mailed or shared. And then we have a formal procedure for folks who can speak to supervisors, myself, and folks. But I would just say it's an important question, Mayor Walker, in how we can all do a better job of that. And I think one of my questions is, how do we do that and still maintain confidentiality? I want to talk to more, was it Molly, about the quarterly lunches, because it's an open invitation, and it also brings people into the room with each other, which is great, with social support, but it's about people being aware of sharing their own stories. And so want to have formats that are both confidential as well as formats that can be more public.
All right, thank you.
Region 10 has done a number of things over the years. For a number of years, we were doing consumer satisfaction surveys and then stakeholder surveys. I'm sure a lot of agencies here received our stakeholder surveys. We did 2 years ago take a break, and we'll be gearing back up again because our response rate just kind of nosedived after about 6 years of doing them annually. And we're going to begin to do them again, but probably biannually rather than annually. We do have comment cards, of course, across our agency. We also, as part of an individual's quarterly review of their treatment team, they give their impression or their satisfaction. They're just asked if they're satisfied. There's not a, it's part of their whole ISP, so it's not as intensive. And then the other thing that we're starting is, about a month ago, we started collaborative documentation, which is we're working towards so that when people sit down with their clinicians, they're sitting down together around their ISP, they're planning their progress notes, and so they're working kind of right there together, reviewing the documentation as it goes in the system. We also have a consumer advisory council that is been in existence for a while. It's kind of undergoing some changes right now, but that, and that's kind of an open invitation for people to speak there. Myra, you might want to talk about whether you feel like we get really good feedback in that venue. So it depends on how many consumers are in the advisory committee at that time. A lot of times we've had some of the same people over and over and over and over for years and years, and we don't get probably the mix that you might be asking. We serve 9,000 people a year, and we probably have 30 consumers in the consumer advisory committee that are regular visitors. So it's always a topic of discussion, how to get more input. And to get more input on a regular basis without burning people out about it.
So in addition to soliciting qualitative feedback, and I often don't have to solicit that. Often people will stop me in the streets and say, "Do you know Roxanne? Roxanne is amazing. Roxanne is wonderful." So in addition to doing that, because we are funded completely by private donations, we have to be able to provide qualitative outcome measures. And Partner for Mental Health was the recipient of 2 very significant gifts from the Community Foundation this fiscal year. With part of one of them, we have invested in a very sophisticated metrics and outcome tracking software. Every single person that comes to Partner for Mental Health defines what their goals are, and we at Partner for Mental Health define success based on how many people meet those goals, which is really interesting. That means that at Partner for Mental Health, we are only as effective as our community partners. Because if you come to us and say that you're a person experiencing schizophrenia and you need vegetarian, diabetic, pureed food delivered to your home, Partner for Mental Health isn't going to do that, but you've told us that that's what you need. So we don't define ourselves as being successful until we have helped that individual actually close the loop and get that service. Thanks to this new technology that we have, we are able to track all of that and see how successful we are able to be on behalf of the people that we serve. And I can tell you that the 2 biggest stumbling blocks that we have here in Charlottesville are being able to get people timely access to psychiatry and safe, stable, and private housing that is conducive to health, wellness, and recovery. And because of the unique way that we measure success, Partner for Mental Health will not be as successful as possible until, as a community, we come together to find solutions to those really complex and expensive problems.
Thank you.
And I'm also a data geek, and I'm happy to geek out about outcomes data with anyone who wants more information.
Really quickly, we just ask, we go to our members. Quarterly, we send out a survey, and the questions are very, very, very specific about what do you need and how can you have a better experience it on our own, and we take it very seriously. We allow it to be anonymous with confidentiality, and it allows you to be honest with the answer, and we let them know. We come back with it. So, and then for us, as I heard Anna said, we have to hold our feet to the fire also. So a lot of the grants that we go out for are from our members. What would you like to see? And so we have to, of course, generate results from that. So it makes us all invested. It makes the members invested. It makes us invested in a result-oriented group. So that's how, and we get responses back from our members, and then also that stretches out into our community. I hear you're doing this. I hear you're doing that. So that word of mouth is pivotal for on our own. That's it.
Thank you. All right. Anything else? All right. Thank you all for coming out this evening. Appreciate your time, and look forward to the follow-up and continuing the conversation. Have a good evening.
Thank you.
Meeting adjourned.